Welcome back. Thank you very much once again. I think this time we planned it in a slightly different way. We thought what I told last time is that we had some discussion about three cases, and then I told that okay, I'll send the case details, my PPT to all of you, and then maybe you can come back with some of the suggestions, comments, and then especially I said that the last two cases, which I also need some kind of like a suggestions from your side, so that I'll be able to manage them better. But now, like midway, I think things have changed slightly different like that, and then that is where I say that now. Uh, and then in the questions when it is lifted now like listed out, I found somebody asked what is this hue and cry about bipolar disorders. What is that? Why so much of that? Then my simplest answer to this is, sir, I know only thing about bipolar disorders. That is why I am talking about bipolar disorders and nothing else. My knowledge about rest of things is very limited. So whatever I thought I'll share with you, and then I got an idea. Like let us discuss. I think this is a very important thing, and that is why I wanted to discuss about the cases and all those topics, and then we'll go by that. But started with that, and then in between I felt let me take some opinion from all of you, and then I put up a question. I definitely I owe an explanation regarding that question. I'll definitely can explain to you. And today's topic presentation, mostly I'll be trying to focus why are we discussing so much about bipolar disorders? Is there any need? And then what is the requirement? Are there certain things which demand more discussion, more attention, more kind of a focused kind of interaction regarding bipolar disorders? I'm going to talk about it. And then maybe I'm sorry if that's not in a continuous stream, and then the in between it's broken a few slides, and then it will be slightly going on to a different kind of it's not topic but different kind of a subtopic it will go into. Maybe that time I'll stop and I'll request the questions from you. And today we also thought that some of the questions which I find an interesting here, some of you can come live and then ask questions. We can have a discussion. That's also we thought we will do it today. But before that, there are some questions, and then very specifically, 3, 4 doctors have responded to me with the specific answers. Dr. Dushyant, Dr. Ishwaran, and then a few more doctors have responded. I think Dr. Dushyant has given a very elaborate thing on my two cases. The one case where I had about 13 episodes, brief episodes of mania and depression, he said that, yeah, his comment is that I would say that lithium has failed in this case. So I will not expose the patient to its potential adverse effects. I think I respect that. But sir, before this, let me. I think last time Professor Deepanjali has put a question to me in which she clearly told that, Dr. Reddy, why are you limiting your lithium only up to 900? I think I didn't understand the question very clearly. What she was trying to tell is that, why are you keeping it only 800, 900? What are the therapeutic levels? Madam, therapeutic levels are definitely between zero point 0.6 to zero point 0.8, no doubt about it. But if you say that you should have gone up to 1.1 up to 1.2. Yes, madam, you have a point. I don't know whether you are there today or not. You have a point, but sometimes going up to 1.1.2, it's a little bit of a problematic thing. I'll be a little bit uneasy with that. Of course, these are one of the resident cases where you had 13 episodes. You should have gone up to that. You have a point. There is no doubt about it. But generally, it's not that. Even that point today, I'm going to discuss why 0.6 to zero point 0.8 is considered reasonably accepted therapeutic level all over the world. So what Dr. Dushyant says is that, okay, right, you have given enough of lithium. I would try this patient with olanzapine and quetiapine. Absolutely, sir. Quetiapine may not be, but olanzapine I have been trying of late, not only as an antipsychotic, but also for the prophylaxis, a few patients where there is not much of a weight gain. But unfortunately, this particular patient, what you're talking about, every time I started olanzapine, I was starting olanzapine, only risperidone, he was only on 2 brief episodes. He used to put on weight, and then I used to pull it out, something like that. And also aripiprazole. My experience with aripiprazole is very limited. And one important thing, what he told is that he would pay a close attention to the sleeping patterns. And he says that sometimes a disordered sleep pattern may contribute to precipitating episodes. Early identification may help. Yes, I agree with that. The early warning signs we all used to talk about, signature relapse symptoms we used to talk about, but it's always not that difficult, especially in the kind of, the background where we operate. And he said valproex, divalproate also, but generally I'm not using. Sir, oxcarbazepine, you also said not much of use. So he said that you could have tried olanzapine. That's one reason is that he always put on so much weight. So other suggestions were not there. For this other case, he again said that lithium did not seem to help, lamotrigine did not seem to help. You try with olanzapine and fluoxetine, especially because he has a lot of obsessive compulsive symptoms. Thank you very much, Dr. Doshin, for that. Let me see, definitely, at least one patient I will try on olanzapine. And there are other questions like some of these things, roll up aripiprazole again, mixed episodes. I don't have much of an experience with that. Uh, right. Somebody asked, bipolar being a self-remitting illness, treatment adherence is a question of interest. Exactly, exactly. I'm going to touch one slide today on what is going to be the compliance rate in bipolar disorders, which is very, very important. I'm going to touch on that. And then there are definitely a question asking that, what about you are talking only about pharmacotherapy, lithium, valproate, olanzapine, quetiapine, lamotrigine. What about the psychosocial factors? What about the environmental factors? What about the Actually, if you ask me, at least my opinion, I do not really give much of an importance when it comes. Maybe they play a role, but as far as I am concerned, they play a minuscule role in the precipitation of the episodes of bipolar disorder. Actually, madam, the particular question what I have posed to you, it is very clearly framed. Each word is not like in a very specifically framed in such a way that it is pushing you to the extreme. I'm sorry, I pushed all of you to the extreme. It is pushing to the extreme the biological etiology of bipolar disorder. I'll come to that question also. It's mainly to see that it's a biology. Pharmacotherapy is the mainstay of treatment in bipolar disorders. Psychosocial support does help, no doubt about it. But CanMat 2018 also says that the highest in the support-wise, evidence-wise in bipolar disorders in psychosocial treatment is nothing but a simple psychoeducation, not CBT, not IPSRT. It's a simple that is exactly that, which I also feel it's correct. Not much of an importance to that. And right, sir, Professor Dr. Javed has commented bipolarity is difficult to manage and schizophrenia. Right, sir, definitely you're finding it very difficult. And somebody asked me, why did you start lithium and not valproate? I think I've been talking so much about valproate and lithium. I don't want to talk again about it. Something like, other SSRIs and other so-called mood stabilizers. I think this also we discussed. And then maybe while we go along the, like today's presentation, I'll also talk about some of the other things. Importance of, yeah, correct. Somebody talked about, you tell me something about important hints about serum lithium level estimation. I'm going to talk. I'm going to spend at least about 10 minutes on this serum lithium level estimation. I've shown you a few slides I'm going to discuss today. Once again, on that. And somebody said, all this hue and cry about bipolar disorders is because it's being underdiagnosed. Sir, please, it is because it's being overdiagnosed and overtreated. At least in my concept, it's because of that. I think this is the few questions. And then maybe while we move along, we'll take up questions. Right now, going on to the somehow I thought I limit my number of slides today and then go more and more for a discussion, but somehow it happened because of this certain points which I thought I'll highlight. Once again, I ended up with a little bit longer number of more number of slides. But anyway, let's see that how do we go about. He is the principal investigator of STEP BD, Systematic Treatment Enhancement Program for Bipolar Disorders, which is one of the largest naturalistic studies which was conducted in bipolar disorder more than a decade back in the same period as STAR-D, STEP BD. Somebody asked me last time what it is. He is the principal investigator where about 4,500 patients are recruited. And this is his statement. A little bit paradoxical. Yeah, there are challenges. And that is the reason why we have to discuss why there is so much of a hue and cry about bipolar disorders. That is why we have to discuss about it. And when it comes to this, I always keep this. This is my bipolar clinic. This is a vision very clearly, reinventing very clearly, sir. 100 years back, Kreplin has said that classified into manic depressive psychosis and dementia precox. This is episodic, this is continuous illness. Episodic means good prognosis. I am trying to see whether reinvent the recovery as a reality. That is why very specifically, very specifically focused question I asked. Thank you very much. It's actually wonderful response. So many of you responded. Almost, I think about 25% of you responded to that question, which I posed. Do you say yes? Do you say no? Do you say don't know? It's great. And then it's such a pleasant surprise for me that, I saw the majority of the answers says yes. I'll show you the poll result also. I'll show you that. I didn't expect because with the kind of a literature bombarding us saying that bipolar disorder is a chronic disabling disorder with a lot of disability. This is it. Every page, every textbook, it starts with that. I understand there are recurrences, but there is recovery. Before that, sir, some of the seniors have responded saying that, Doctor, what is this? You said promise. I understand, sir. I stretched this question a little bit, pushed it a bit more, purposeful, very clearly each word I framed it in such a way that I'm stretching it and stretching it and stretching it to the point where they say that, but such a fantastic and such a pleasant surprise, majority of the answers are yes. Yes, when people say no, they have a definite point, but this is something excellent. I was really very happy. Now, see this. One is a definite diagnosis, I think no problem. Any age group and any severity, whatever may be the severity, whatever may be the duration, 2 months, 3 months, 4 months, 6 months, 7 months, 8 months, frequency. It could be the second episode, it could be the 10th episode, like my patient where he had 13th episode. Which psychosis symptoms? Oh, one of the very severe, long-term duration, 10th episode, 15th episode, with psychosis. And you all said that, yes, complete symptomatic recovery. Sir, promise. The reason why I specifically use the word promise is to push you people. I know, especially as a medical doctor who has been practicing for a long time, we all have been taught not to promise. You will never promise. Even a simple case of a viral fever, you don't promise. You say that you'll get better. Don't worry, you'll be all right. You'll get better. I know. But still, this word why I used is that if I stretch it to that, still you are confident that you can give complete recovery. Do you remember some time back I asked you a question? Psychiatrist, does he treat a depression or mania with the same kind of a conviction as a physician treats a typhoid, a tuberculosis, and a malignancy? Do you treat that with the same kind of a conviction, whatever is the prognostic thing? I always feel that we don't seem to be. But today's answer was fantastic. Yes. Right? Now, yes, sir, we don't promise. But things, sir, I think we, that's why I put it. We don't promise, but we do convey promising positivity in outcomes. Let me spend a minute here. Suppose I am a general practitioner. A patient is a general practitioner. Sometimes we see about 150 to 200 patients. Somebody walks into my clinic, and then I'm sitting and then saying that, and he says that, Doctor Saab, bukhar hai. I'm having fever. How long? 2 days. What? Headache, and then like a little bit of cough. Only 2 days? Yes, 2 days. I'll just hold the hand and then write the prescription, on antibiotic, something I write, on tonic I write, and send him off. Fever, cough for 2 days. I said, don't worry, anything will happen. I don't promise. What I'll say? The next patient walks in. Doctor Saab, I have fever. Yes? Okay. Kab se? How long? Doctor, I have been having fever for 4 months. Huh? 4 months? Okay, come, sit here. Come, sit here next to me. What all problems you have? You have cough? Yeah. I take history for about 10 minutes. The first patient asked me, why don't you write some investigations? Why don't you do some routine? Hey, no need, dear. Nothing will happen. Take this medicine and go. That's it. Don't worry. Okay. This patient, he doesn't want, but I'll say that I'll admit him. I'll do investigations for worth of thousands of rupees. Why, what's the difference? I've not promised, but the way I talked to him, the way I conveyed him, don't you think it is a kind of a promise which is conveyed non-verbally to the patient? Yes. Here, let me come back to that. Now, very specifically, why, right? I basically, let me agree that a doctor is not supposed to promise. Yes, as one of the doctors told that, like, you're only a human being, you're not a god to promise. Yes, I agree. But what's happening? What is happening? Why? See, like, I don't say promise, but to the extent you have to go. The point is, I'll say that. Everybody Googles. Everybody Googles now. When you prescribe, let me give you an example of a situation. When you write an antidepressant prescription, suppose this guy goes and Googles, somewhere he finds a study, he says that only 30% of patients respond to antidepressants. And then somewhere somebody says that, like an antidepressants are not antidepressants. And the most dangerous, I say that FDA black box warning, last time also I told that antidepressants increase suicidality in adolescents. Again, I am asking you the question, sir. A parent brings to you a teenager with a clear-cut depressive episode. You write antidepressant and this man goes back and looks at it. He will be unnerved. He'll be disturbed. So that is the time. You're not generally supposed to promise, but you have to emphasize in spite of all those things. This is where sometimes I say that it's like, I know that it's not. When a patient is recurrent depressive disorder, when a patient has got melancholia symptoms, sometimes I make a statement to give them that confidence, to make them feel more confident, to make them feel positive. Your depressed patient is negative. He has got inferiority feelings. He has got hopeless, helpless. He walks into a clinic with all those things. Don't you think we need to give a little bit more when you know very well that this patient is going to improve? This is where I make a little bit of a rash statement, little bit of a so-called, some of you call me an arrogant statement. I tell the patient, even if you don't want to become, you're going to become all right, man. I don't tell everybody. I tell only for recurrent depression with melancholia. I tell them because I see a complete symptomatic recovery, which is a possibility here. That is why I say that. So I think our patients, especially in the depressive phase, they need a little bit more of a positive thing from the doctor. Not just saying that these are the facts, these are the results, this could be this could be this. No, a little bit more of that, which is going to give them, you need to instill confidence in them. It's not in psychotherapy. It's a doctor, you have to do that. That is where I said that, that's very specifically. And then again, this is the same thing. Psychosocial factors, environmental factors, I cannot change their psychosocial factors, and then family issues, mother-in-law issues, and alcohol problems, or financial issues. I cannot, it's beyond me. But it's only because it's a biological thing, I can give that a very definite positive response. I'm extremely happy that quite a lot of you said yes. That's the only reason. Nothing else. We don't want to be irrationally optimistic. We don't want to be irrationally reassuring to the patient. But when you know fairly good, I think it's better. It helps the depressive patient to get that confidence, to keep the patient with you, to trust you. The trust, the therapeutic alliance has to be built up. When you know clearly, well, we have to do this. That is why I framed this question like that. Very, very happy that quite a few. And then symptomatic recovery. Yes, sir, symptomatic recovery. That's what we do. As a doctor, we are supposed to give symptomatic recovery. Beyond that functional recovery, yes, he has to go and find out his functional recovery. Not me. I have to get his fever down, cough down. I will make him free of that. Then he has to go and back to his work. That is it. Why should I bother about it? I'll come to it a bit later. That is where I said that I go in explanation. I stretched it a bit more, but still, most of you answered is very good. This is amazing. 61% said that my day is made. I'm extremely happy. You saw that, no? Reinventing good prognosis, reinventing recovery a reality, which is the mission of my bipolar clinic. When 61%, two-thirds of people say that almost. Great. But they have their reasons. 37%, they have their reasons. They may argue saying that some of the extreme case, no? Right, I'll come to it a bit later. I'll come to it. But this is a real fantastic thing which is happening. I think it's excellent. Sir, again, this series I've started, I think this is the 7th or 8th webinar. The very first webinar I started with this. Even when I made this statement also, some people are very upset, very angry. But I think I put it very clearly. This is not out of anybody's arrogance or authority or anything. This is only out of anguish. That's it. That's it. I am nobody to say this is myth, this is not myth. But day to day, every day, you see these things in your clinic, and the way the patients are being wrongly treated or diagnosed, that is the only thing. That's why I submitted that time. This rashness is painted to seek attention. Yesterday in the question that severity, frequency, duration, any whichever episode, and promise is again painted to seek your attention and nothing more. Nothing else. And I'm sorry, I'm showing this slide the umpteen number of times, but I still say that only to see that why there is so much of a hue and cry about bipolar disorders. 2014, first World Bipolar Day. This is my slide there. This is second point I asked for. This is the third point I asked for. Out of which these two are done. This is not done yet. This is not done yet. I wish that someday it will be done. Now let us just let me run through this CanMat 2018. CanMat 2018, this is what we all talked about in 2014. We have been talking about this mood stabilization for quite some time, about this term and all that. CanMat 2018, sir? After 2 decades or 3 decades or whatever it is, this term has been removed from CanMat 2018. And then CanMat also has done one thing. I don't know whether any of you noticed it. There's another important thing here, which for today, I don't know how much of importance, but this is going to be a major important issue in our future, now like looking at the bipolar disorders. Recurrence. Right? CanMat 2018 has removed the term remission and relapse. There is no remission relapse according to CanMat 2018. It's going to be only recovery and recurrence for whatever may be the reason. These are the very, very two important things it has done. But I'm happy with this. Now like mood stabilization. Right? I think we should stop using this because whatever may be the reasons it's been done. And then recurrence. This is what? Relapse and remission have been taken out, and these two. But this I feel that, like we can discuss about some other time, but I think this again, it's not going to be very correct thing. Sustained remission is recurrence, which I think we are going to miss in this. Right. The first one, mood stabilization. The term has been removed. Second, what I was requesting is that remove bipolar. Bipolar 2 disorder is a myth. The reason why I said that, why is there so much of a hue and cry? Because there are lots of inconsistent things happening in bipolar disorder, which is otherwise a good prognosis disorder in psychiatry. Non-psychiatric disorders, there is one particular disorder, mood disorder, which is a good prognosis. That particular disorder, with all our kind of, like conceptual confusions, we have been doing all that. That is why there is more and more discussion about it. See this 2019, I think this also, the very first day I presented this slide, just for now to refresh that, I am putting this up again. Abandonment of bipolar 2. This is in the journal, Canadian Journal of Psychiatry. So two have gone, and that is why we need to discuss. That's why we need to know. That's why we need to now have a kind of a debate or discussion about this, because continuing to diagnose bipolar 2 disorder can do a bit more of a damage to the patients, management. That's what I feel that. Okay. So this is what. Basically, this is the basic thing which I think about 100 years back, Kraepelin has told that manic depressive psychosis, dementia, two separate entities, good prognosis in the short term, recovery is the rule. This point we'll come to it later. Maybe I'll asking you. I just want to ask you the question. There are about 100 people today here. What is the percentage of chronic mania in your clinical practice? Maybe later in one of the discussions, we can talk about it. Long term, there is recurrence, but still there is a good prognosis. Episodic, this is what it is about mood disorders, right? And then what is the evidence? Number one, sir, this is based on this Kraepelin has made. This is about 100 years back without any treatment, when there is no antipsychotics, antidepressants, no lithium, nothing was there. Almost all patients went home well. That is a natural course and recovery. Good prognosis, right? So do you believe this particular study, 2003 JUT study, which is a NIMH CDS study? This is the results. 20-year-long follow-up this is. 53% of the patients are asymptomatic. 53% of the time patients are asymptomatic, which shows it's a good prognosis. Rest of the things, okay, right, it's all these things. But long-term follow-up, weekly affective symptom, it is 53% of the times it is asymptomatic, right? This again I showed you recently. Even in this affective disorders, 53% at the end of 2 years are asymptomatic. Even at the end of 6 years, 28.2% are asymptomatic. Do you agree with this? Whether it is about 100 years back, Salem study, JUT study 2003, this is 2007, there's good recovery in this. And then this is what I was talking about. Initially, this was remission, this is recovery. Now this is has been cleared by CanMat, saying that this is no more remission. This is what the basis for the question what I asked is that whatever may be the severity, duration, frequency, psychosis, an episode will recover in a bipolar disorder. This is the natural course. Whatever you do, as long as we don't disturb this. What we are supposed to do is that bring this time frame from here to here so that he is free of this. He is freed from this morbidity and suicidal risk of mortality in this episode. This is what we are doing. That is why I said that even if you leave any mania depressive episode, they reach recovery. But how many days? It's going to be 4 months or 8 months or 6 months, but it may be generally it's about 6, 7 months, 7, 8 months at the most, not more than that. But that's quite a prolonged period, quite a traumatic period. The disability is very high. The risk of suicide becomes very high. That is why we need to do it. So I have shown you 3, 4 slides where this is what facilitating minimize morbidity. This is what it is. At this point, maybe I would come out and then let me see that whether there are any questions, and then I'll see that if there are anything, some of you can come alive and then talk, and then right. As of now, there are not many questions, right? Uh, right now, fine. The question is that lithium and hypertension, which antihypertensive drugs? I am not an expert at all, sir, in general medicine. And lithium, the only thing I know is that diuretics, you be very careful in using it. That's the only thing. Maybe I think a general medicine internist may be a better person. Uh, at this point of time, if any of you would like to respond till now in the presentation what I made, you are welcome. Otherwise, I'll move on to the next one. Right, sir? I think I will move on to the next slides. Okay, see that. Somebody is willing to, is somebody going to talk? Is somebody going to interact?
You can please raise your hand if you have any questions.
Is there? Sir, you are welcome. If you are, we will definitely. Yes, maybe later. We'll come back to that later then. Yeah? Okay. Chintan, we'll come back to that later. I'll proceed with my presentation and then. So till now I have told this is what is the the clear picture about it. I've showed you a few slides about the 100 years old back thing, Judd study, and then what is the recovery, and then how to make it early recovery, and then the other slide where showing it affective disorder. But then now this is the problem here. Symptomatic recovery, yes, but is he having a functional recovery? How much? Yes, sir. Functional recovery, once you make it a symptomatic recovery, he's supposed to be going back and doing his job and taking care of things as long as you treat him well, properly, without any kind of either subsyndromal symptoms should not be there, or it should not be, your drug should not be giving any side effect. As long it is, yes, it has to be a natural, unless there are some other factors, some other factors, some other factors. And then the question of bipolar 2. And then the question of bipolar spectrum has come. And then what you are doing is, this is scientifically correct thing. But without having enough tools right now, jumping into that and making overdiagnosis, 300% increase in the bipolar 1 is 0.4, including all this is there. And then what are we doing? Overdiagnose. I've been talking about overdiagnose. Sir, I think all of you, a few seconds, give you a thought. Personality disorder in the differential diagnosis of bipolar disorder. What is this? CanMat 2018, differential diagnosis, perfectly understandable MDD. Perfectly understandable. Cyclothymia miniature understandable. Psychosis very, very understandable. Delusional. But how do you get differential diagnosis of schizophrenia, schizoid personality, schizotypal personality? I understand, because it's a personal disorder is something which starts very early and continues and continues and then continues. But bipolar disorder is an episodic illness with recurrences and then recovery and recurrences. How are the personality disorders becoming the differential diagnosis of bipolar disorder? Borderline, narcissistic, antisocial? It's not my this thing. This is what textbooks say that. How? On what basis? So what's happening here? Where are we going wrong? That means this is very clearly showing one thing. In a certain group of patients, we are diagnosing personality disorder, actual personality disorders as bipolar disorders. Otherwise, this will not. Personal disorder in the differential diagnosis of bipolar disorder, where are we going? That means how much we are over-inclusive we have become. That's a problem. We need to look at it. We need to think about it. And then, this is what I also say, that you wrongly diagnose a personality disorder, borderline personality disorder, as a bipolar disorder. And what is the immediate consequence? Start. How long? I've been talking about it very repeatedly today because there was definitely, we are trying to justify why we are discussing so much about bipolar disorders. I'm digging out all some of the old slides and then coming back again, nothing new here. But one is that you make a wrong diagnosis. Second thing is that the treatment is lifelong. This is where the problem of that. And then not only that, now this has come again. People started talking about there's nothing like schizophrenia or bipolar disorder. The whole thing is one unitary psychosis. It's a trans-diagnostic approach and dimensional thing. There's one of the studies which recently have been done, BSNP study, bipolar schizophrenia network for intermediate phenotypes and the machine learning. And then, see, see, I don't say that there are a few patients which fall in between between the schizophrenia and bipolar disorder. Definitely there are some cases which fall in between. But that doesn't mean that the entire thing you make it as unitary psychosis. Such a good prognosis, what I was talking about is, such a good prognosis, episodes are recovering episodes, that kind of a illness, you get them into join into unitary psychosis and then whole treatment goes haywire and then talk about this. Don't you think we need to talk about this more and more, get some more clarity? I'm so happy. So many of you responded with yes when you said that, yes, this episode is 100%. I promise, in the sense, I don't say that, but it's a promising kind of, which I completely agree. A bipolar disorder episode, whether it is depression or mania, patient has to recover, sir. Sir, again, I say that what is the advantage is that in depression, the patient will be down in the dumps, so low, the family is so low, they don't know whether it's going to come out or not. Only you know if your diagnosis is correct as a bipolar disorder. You can tell them definitely, give me some time. It may take 2 months or 3 months or 4 months or 5, whatever it is. But your patient is going to completely come out of it. This is in the background of all Google literature, what we have, all kind of I don't even hesitate to call it as that no kind of a thing which is going on, frightening people, not effective, suicidal risk, long-term side effect. They need, for that you need to be confident. For that your concept has to be clear. For that you have to have a clarity in this concept of this being, I don't want it to be, like overtly, irrationally optimistic, but don't dump in this kind of a thing. That is where the problem is. That is why we are talking about it. That's what I said that. You think about it, sir. How can a personality disorder, which is a continuous illness, should become a differential diagnosis of bipolar disorder, which is an episodic illness? Unless there is one of those things you totally don't agree, then it's a different issue. All right, I did talk about this. I showed you. For the sustained improvement, one of the papers in 2010 says that average of 7.3 drugs are used. This is where I said that I was so optimistic. I was so more than optimistic when it comes to the episode recovery, but when it comes to the episode prevention, I don't know. I feel that no, it's not happening. That's where I show in the cases, but I'll show the other case also repeat. 7 drugs you use, no problem, sir. You give me 100% or 80%, even 80% prophylaxis. You tell that boy who had 13 episodes, the next 10 years he is going to have only 2 episodes. I don't mind using 7 drugs, but do they? And then somebody asked me, what is the treatment adherence? You see this? I have no problem in giving drugs, but is he going to take? See this. 12 months, this is a study, this is a series of studies. 2003, 7, 16, antipsychotic medication, 40,000 patients, 41%. If you look at this may be one study, some other study may be different. 12 months, 76% discontinuation. If it is 18 months, this is frightening. This is frightening. At the end of 1.5 years, people who continue lithium and continuous basis are only 2, which maybe I don't agree. Maybe 2 of my patients were one of this now, like outliers. 98%. This is not totally untrue. I told you, we have conducted a study with one of the pharmaceutical companies. We have interviewed 500 psychiatrists in India. regarding their drug, like in prescribing practices. I think the average at the end of the day, like when we compile the results, majority of the Indian psychiatrists have opined that not more than 5 to 10% of our patients take or good complaints beyond the 18 months or 2 years. Very categorically. They don't take, that's why I don't write. So I have no problem in writing 7 drugs or 8 drugs, but patient has to take, no, with all the complications. So no point in theoretically talking about it. How do I improve this? Then I come back to that. It's one thing which we have to. Yes, right. Dr. Dushyant also suggested me, instead of this, you take give olanzapine. Definitely, I'll try to. Somebody will say that add valproate, add quetiapine, add this. Definitely. But is it going to show the result, or is the patient going to take? That's going to be the most important thing. No matter, it only works if patient takes it. Are they going to take? If it is 1 year, 2 years, they take. For a longer time, this is a problem. This is something which we have to keep in mind. Right? And then I think this one also I showed. I have no problem in keeping 5 drugs or 6 drugs. This is one of the excellent study. It's about, somebody commented also, doctor, it's about 10-year-old study, but still I say that, look at this. We all talk about symptomatic recovery, but functional recovery, what is the main obstacle? 2 obstacles for functional recovery. One is your drug, second thing is cognitive impairment. See, sir, here, lowest is with lithium monotherapy, and then untreated individuals. Last time also I told you this. Combination therapy, your 7 drugs, they're going to give the lowest functional impairment. And then what? Significant functional impairment with the combination therapy, not lowest is with lithium. So you give 7 drugs to prevent the next episode, but at the end of the day, he functionally significant impairment. What is the point? This is what we have to. No problem in giving 7 drugs or 8 drugs. That is the problem. All right, maybe after the next 2-3 slides, I'll again come out and then see that if there are any questions. This is what I told that. Bipolar disorder diagnosis not a problem. This is what it is. The problem is both need a serious treatment. Today, I think the most controversial thing in the management of bipolar disorder is management of bipolar depression. Right? Right. Okay. One of the reasons why bipolar depression, antidepressants are not used is switch. I think I showed you also at the end of 20 years, 20-year follow-up study. Those with the positive family history also, there is about 25% of switch, nothing more than this. Now, let me, before I go to the next slides, let me again come out of this and see whether there are any questions. Yeah. Somebody said, right. Oh, yes. There are some questions and right. One is that.
Sir, Dr. Nirmal is there. Dr. Nirmal would like to ask this.
Dr. Nirmal, yes. I was looking at Dr. Nirmal's question only. What is long-term goal in BPAD treatment, recent treatment guidelines, and how do you gauge functional recovery? Dr. Nirmal, would you want to come alive and then talk, say a few things? Welcome, sir. Dr. Nirmal, can you talk? There's some problem. Chintan?
Yes, we can go to we can answer his question.
Yeah, right. Let me see. Definitely, I think it's a question which I think sometime back in the very first session itself, Dr. Charaneshwaran asked me. Mood stabilization, the so-called is like the pathology. What is the long-term goal in BPAD treatment? Exactly to see that there are no further episodes. Absolutely, sir. No doubt about it. But theory, it is not getting translated into the practice, except in maybe a very, very small percent of the patient, which to a large extent, I say that it's a natural course. I don't know whether you were there in one of my previous lectures. Today also, I'm going to show one of the slides. I'm only repeating the slide, nothing more than that. Totally no episodic period. The next is that less frequent episodic period. A third is that less severe episodes period. These are the long-term goals, but are we able to achieve? If we are not able to achieve, then how do we subject the patient to 7 drugs is my only thing. Recent treatment guidelines, I think CanMat 2018 is one of the recent. After that, I don't know whether any of the Americans and World Biological Society have done, but CanMat 2008 is an excellent guideline. In a way, for the first time, they introduced hierarchical model, which is very good. How do you assess functional recovery? Excellent question, sir. Sir, for me, from my side, I don't know whether people like it. My job as a doctor is make the patient asymptomatic. Get him out of his typhoid. Get him out of his, make his fracture fuse properly and well. Let him control his, cough and then hemoptysis and then treat his tuberculosis well. Get him out of depression, make HAM-D less than 7. Make YMRS less than 5. Functional recovery, generally I look at it as reaching the pre-morbid state. How he was functioning. A housewife who was taking care of small things at home, that is a functional recovery. That's it, reaching the pre-morbid state. But reaching the pre-morbid state, there may be a lot of blocks. I generally keep on the lighter side, I keep telling that I recover from the illness, but if my father-in-law is supporting me, I will not work for the next 1 month. If I don't have a rich father-in-law, if I have to support my 2 of my children there, I'll start working even before my symptoms are recovered. It is a lot of individual thing, which is depends on that. But my point is, cognitive impairment is not in our hands completely. It's a part of the biological process. If your drugs are the reason for the iatrogenic, the reason for impediment for functional recovery, we need to have a serious relook at the number of drugs, the long-term duration of drugs, and then what are the significant side effects of drugs we are giving. That's the only thing. Right. Why not valproate preferred? I have answered. When you're describing a spectrum concept, right, I think it's a very good question. Unipolar mania, sometime back I touched on that, maybe sometime later. One of the recent papers of Jules Angst very clearly says that there is an entity called unipolar mania. We'll see that. Schizoaffective disorder. This is that kind of a unitary. I personally, I would mostly avoid this diagnosis. For me, this is a kind of a wastebasket diagnosis. More than that, it doesn't do anything. Once we start making like this, like that mixed episodes, mixed bipolar disorder, which fortunately has been taken out of DSM-5, this is also something, but no, there's a lot of literature on that, but mostly I don't diagnose that, so I don't know. If symptoms in bipolar mania does not subside with 2 mood stabilizers, here I think we have to look at, are you talking about the acute episodes, sir? Are you talking about the chronic prophylaxis? I'm not sure about what you're talking about this. So yeah, right. Borderline symptoms and bipolar symptoms in first episode, there's a PD in the DD of, sir, if it is in the first episode, I have no problem. We, as a doctor, as I told that we all are supposed to be making a diagnosis and we all have the right to make wrong diagnosis. There is no problem at all, sir. But if you do that after the 10th, it's not easy, sir, borderline personality. I've been struggling and then struggling. Borderline personality, OCPD, and then bipolar disorder, it's a big problem. Maybe sometime we'll take up borderline personality and then bipolar disorder, and then we'll come to that. Clear diagnosis is the main problem with good clear diagnosis. Mostly it's correct, right? Benzodiazepines in acute cases, definitely you can use. You can use it temporarily for a sleep, for control of daytime sedation, to control the motor activity. You can perfectly use that. There is no problem at all. I think these are the few questions. Why bipolar regarded as a biological illness? Sir, it is nothing but biological. If we are still doing a mistake that the psychosocial etiological factors in bipolar disorder, I think it's really, I feel sad about it. It is biological. There is no doubt about it. Schizophrenia, bipolar disorder, they are all biological. Even OCD, this is mostly biological. Psychosocial factors do play a role in everything. They play a role in cancer. They play a role in heart attack, my MI, and then they play a role in diabetes, hypertension. But doesn't mean that no. These are biological. There's no doubt about it. Right, sir. I think I'll go back to my presentation. I think I think I stopped at a point where I was saying that, right, I'll go back to this and then say that. Right. Once you diagnose bipolar disorder, the dictum comes as these two. The reason is switch. That's where I showed that even in family history being, at the end of 20 years, it's only 25%, 75% of them, you remain unipolar depression. So nothing to worry about it. This is another my favorite slide. This is nothing from none other than Frederick Goodwin, who has written a book on manic depressive psychosis. If you can't use lithium or won't use lithium, get out of the business of treating bipolar disorder. Absolute, no word, no mentioning of words. Get out, that's it, he said. I respect. Lithium is the gold standard, I respect. I do prescribe lithium, there's no doubt about it. I showed you many cases where I've been I think I showed you 5 cases. All the 5 cases were on lithium. But look at this slide. This is UK based, it's old, not like in 2009. It's about 15 years, right. 1995, 43% of patients were on lithium. Come 2009, 16% were on lithium. My goodness. What is this? Rest of it, no, let's not bother about. I think we don't have time to look at all. But only this point. This one is 1995, 43% were on monotherapy of lithium. Come 2009, there is only 26%. And Frederick Goodwin says, get out. We are not getting out, but we are treating patients, but we are not giving lithium. Then let's come to 2020. 2009, somebody said, okay, old study, 2020. This is the prescribing pattern in the last almost 2 decades. Yeah, right. This is lithium from 32, 33 to come down to, it's like somewhere here, 17, 18. All mood stabilizers, this is red. Starting from 60, it's come to 30. This may be one odd study. This may be one study does not make the whole thing. This may be one particular thing which I like, and then this goes with my kind of a thinking. I am putting it to you and then trying to show that I understand all those things. But still we have to understand why the practitioners are not writing mood stabilizers. It's going down like this. Why? Why these so-called second generation antipsychotics are going up like this? Are we doing something grossly wrong in the management of bipolar disorders? Or whatever is being taught to us in algorithms and then protocols, practitioners are not very comfortable or happy with the results, and they're changing to their own tunes. I do not know. I don't know. But these are the facts, sir. Look at this. Antipsychotic prescription has gone up second generation, 19 to 52%. First generation, obviously it has come down, very clear, 7 to 1.7% in this period of 20 years. And then it's gone up. Mood stabilizer, gone down from 62 to. And then primarily by a decrease in use of non-lithium mood stabilizers, valproate and carbamazepine. Last time also I told, I am extremely happy about this finding. I'm extremely happy because this is what has to happen. But why this is happening, doctor, I do not know. I feel that there is some truth in why people are not writing, because they are fed up. They're looking at the results, staring at them. 13 episodes in spite of giving lithium for 12 years. Then which doctor is going to continue? I think as Dr. Dushyant told, stop it and then go to like an olanzapine. Is it that? I don't know. My feeling is that I think that is what is happening, and that is why we need to discuss more and more about bipolar disorder, because it makes so much of a difference. The kind of a polypharmacy, rampant polypharmacy, which is there in bipolar disorder, is not there in schizophrenia, not in any other. This is because we want to, I think Dr. Nirmal asked, what is your long-term goal? I want to prevent the next episode, next episode, next episode. This start so-called mood stabilization from, that is where that, theoretically it's fantastic. I think sometime back I told that theoretically concept of mood stabilization is fantastic, but clinical day-to-day practice, it seems to be a bit of a disaster. It's not working, and then the problem is. Yes, lithium, right? Coming to lithium, right? I think I don't want to lose track of this, and then that's right. We started with lithium, and right, let me. This is the one, and then this is what is happening, and this is what is happening to lithium. It's decreasing, and then this is what it is. It's been decreasing, and I'll show you the particular first paper, 1954, Morgan's cow. 38 patients. This is come in the bipolar disorder 2018. 38 patients in a manic state. All right, whatever it is. I think you can just read these things. This is what, out of this 30 patients with lithium, spectacular, some, no effect at all. This is almost about 70 years back. John Cade is the first one who introduced lithium, but I think lots of work on lithium in bipolar disorder, especially mania, is by Morgan Scow. He was not very recently, I think just almost about 3-4 years back, he died. He started a group, international group for management of patients who are on lithium. And then he did lots of work. He himself took lithium. His brother was a bipolar disorder patient. So he himself took lithium. And then, you know what is his statement when he took lithium? And then there's a paper. Yes, lithium is a good drug, but this produces a lot of, a kind of a dullness, lethargy, and negative feelings. I wish some other drug comes which can replace lithium. This is what Morgan Scow told almost 2-3 decades back. But anyway, that's history. Right. Concentration of lithium in serum remained 0.5 to 2, sir. I think that's what Dr. Deepanjali madam, when she asked me, Dr. Reddy, you're stopping at 900, why don't you go up to 1.1, 1.2? She has got a point. Before this, sir, last time at the end of my presentation, I put a slide. I requested you, any of you get me some references. One of that is that lithium 0.6 to 1.2 is the therapeutic level. Where is the evidence coming from? Is there any evidence study where the different arms are there? This particular range is not effective. This particular range is effective. I requested you whether any of you can provide me some data. I don't find data. I actually sent you Nolan's study, which I'm going to discuss now. I also requested you, what is the study, where is the evidence for valproate between 50 to 100 or 125 being the therapeutic level? Show me some data where I can take the evidence. Why are we just prescribing drugs without much of an evidence? That's what I asked. This is in Scout's study, the values were at this range. But somehow, this also I found, there's a strong backlash against lithium prophylaxis. Lancet itself, another therapeutic myth, question the validity of the findings of lithium effectiveness. This is almost about 4-5 decades back. I know when I was reading this article, I came across this, so I thought I'll put it up just for I cannot comment anything on that. I don't have any opinion on this, but this has come, and this is the study. This is almost like a first study about lithium, right, sir? Right. Somebody asked me, and I asked you, what is show me the evidence. Somebody asked me, what is the therapeutic level which is useful in the management of bipolar disorder? We all know that it is between 0.6 to 1.2, and some people say that 0.4 to 0.6 also work. Look at this, sir. What is the optimal serum level of lithium for the maintenance treatment of bipolar disorder? This is a task force. International Society of Bipolar Disorders. Yeah, this is the group I was talking about, which Morgan Scow has started. International Group for Study of Lithium Patients. This is a group, International Group for Study of Lithium Patients. These two together brought out a task force which contained all these people. All very, very senior people and big people. Nolan was the main author. This is coming 2019 August. They published their result. The task force was established to go and find out what is the optimal level for serum level for lithium for maintenance. Go and look into all the studies and get the data, meta-analysis and get the data. That is what the clear guideline is for that. Right. Systematically review. Right. This is how they started. At this point, please don't find fault with me for being a little bit. See, I started my talk and then my question and then this one, hue and cry about bipolar disorders to show them they are positive. They are good prognosis disorders in psychiatry. They are complete recovery disorders in psychiatry. When I put the question with all the stretching too much, still I put the question to emphasize that the promise is that they recover. So I started with a positive note only, not on the negative note. But some of these things which you see that lithium is a gold standard. I showed you get out of the business and then that the lithium level is decreasing, and then Morgan's curve study and latest 2019 study. What is it telling us? Key conclusion. 70 years. This is what the statement they made. Given that lithium has been available for treatment of BDs, there is no study, not a single study which could satisfy, they put 7 different criteria, not a single study which could satisfy all the criteria. Right? This is the conclusion, sir. The paucity of data makes it difficult, if not impossible, to formulate confident evidence-based recommendations for the dosing of lithium based on monitoring its serum lithium level. I am completely collapsed after seeing this paper. They said that it's virtually impossible. So what they did is that when they could not find any single study which could satisfy the criteria, whatever the result they published is by a process of Delphi. Delphi is nothing but all 10 people sit together, pass around a questionnaire, and then like what we did in right, exactly what we did in the opinion poll, they say that which is the level which is based on that, like a common, based on the Delphi process, they gave us these results. Nothing more than that. It is not based on any like a meta-analysis or anything. See, 10 people, 10 or 12 or 15 of the task force people sat together and then passed around a question, which level is more? And then took the majority and gave us this. Consensus. They said 0.6 to 0.8. CanMat categorically said 0.8 to 1.2. Okay, that's a different discussion. Sometime later we can have it. What about this? Children, adolescents, elderly patients. The evidence is lacking. There's no evidence. There are no papers. There are no papers. Right. Somebody asked me, right, best timing. Last time also we discussed. No study was found that addressed this question. Lithium has been there with us for more than 7 decades. I think this is the 8th decade. So this is again based on the consensus, right? So now there are questions saying that why lithium is not being prescribed frequently. The young psychiatrists have lost, they don't know the art of prescribing lithium. There are thousands of questions. But with this kind of literature, somebody afresh, see, I have been in practice, you have been in practice for 3-4 decades. We have been practicing, we see some positive, good results. If some youngster sees this, do you think he's going to prescribe this, especially with the kind of a narrow therapeutic window and all the side effects and all things? So obviously he'll switch over to some other drug like valproate or something. So we have to correct this first. How do you correct it? There's nothing like that. So, right. That is what is the lithium story. The second point what I told is that invariant use of mood stabilizer, infrequent use of antidepressant, that is what CanMat 2018. Right. This is the management of acute bipolar depression. What are the drugs? First line, quetiapine, lurasidone plus lithium, lamotrigine, lurasidone, lamotrigine. Second line drugs, Devalprex, SSRI. So antidepressant drugs come as a second line in the management of acute bipolar depression. The only fear is that there's a fear of, I don't see it here, the fear of switch, risk of, right, risk of switch. So according to CanMat, don't prescribe SSRIs unless you try some of these first line drugs and only come to them. Second, yeah, ECT and all, let's not worry about it now. This is what CanMat says. And then let us look at last 2 decades prescription practice, the same paper. Why? CanMat guidelines are saying something, clinicians are writing something else. Right? Mood stabilizer increase from decrease, antidepressant without a mood stabilizer. This is again another mind-boggling thing. Antidepressant prescribed without any mood stabilizer increase from 17 to 40%. Theoretically, this is wrong. But we did a dissertation work by one of my students. I think sometime back I told that 2 arms. Only one is only on lithium, one is only on antidepressant. There's a lot of criticism saying that how can you give only antidepressant for bipolar depression without giving lithium? I said, we'll go ahead and then see what's going to happen. Antidepressant, lithium were equally effective when it came to like an efficacy wise. So people are, some people who are finding that why do I give second drug, third drug like that? So antidepressant prescription has increased. I think I showed you that slide. I'm sorry, I'll run back quickly and then show you. No, sorry. So antidepressant prescriptions have increased in spite of CanMat saying that it's in level 2. This is the one, sorry. Any antidepressant, this is the increase. And here you see antidepressant without mood stabilizer, which was from 20%, it's gone up to somewhere around 50%. So if you take this, I don't know whether this is American Journal of Psychiatry 2020, but I don't say that this represents the entire prescription practice all over the world. But if you take a sample of it, prescription of mood stabilizers is so-called lithium valproate, carbamazepine is decreasing. Second generation antipsychotics, which have been promoted as prophylactic drugs, olanzapine, quetiapine, maybe some aripiprazole may be increasing. Antidepressants, in spite of all the fear that has been created, still antidepressant prescription is increasing by the practitioners. If you ask me, I'm very happy at this. This goes against most of the theoretical thing, but I'm very happy. I use antidepressants. I use antidepressants very clearly. Maybe I don't use without them. Now maybe I'll start using without mood stabilizer also. Or as I told that keeping olanzapine as so-called prophylactic drug, I'll start using. So this is what, right? Recovery from each episode, everyday clinical experience, but people talk about functional recovery. This is what I talked about. Immediate next episode. I think sometime back outside. So today we treated mania and depression. You just don't know what's going to happen in the future. You know that there's going to have an episode, nothing more. Episode. Yeah, here I think maybe some of you please respond, sir, or some of you want to answer also. I keep asking every time. In your clinical practice, some of you are very senior practitioners. What is the percentage of chronic mania in the sense? A manic episode going beyond 9 months. I have shown one case with that, but in your experience, a chronic mania, a manic episode going beyond 9 months, what percentage of your manias have that? Please give me some information, sir. Right. Personal disorder. This is why we should discuss bipolar disorder. Right, this is what I said. Now, like if you want, you need to have a clear-cut concept. This is functional recovery, asymptomatic, the treatment you give based on the diagnosis, what you make, and then the nosology is DSM-5 or ICD-10, the concept. If you have a clear-cut concept, this is what, sir. For me, mood disorders are good prognosis disorders. Majority of the MDD episode is curable. Bipolar disorder, every episode is curable. Every episode, bipolar disorder, if the diagnosis is bipolar disorder, every episode is curable. That's what the question I asked. That's what 60% of you answered me in the positive sense. If we have that concept, I'll tell you. Last year I had a patient. There's no doubt about it. I think I discussed also. No doubt about the diagnosis of bipolar disorder. I've been seeing that patient for a very long time. Unfortunately, last episode, depression is prolonged beyond 4, 5, 6, 7 months. You name it, I've tried it, including tricyclics, gave ECT, ketamine. Hardly 2 patients, I think I gave ketamine, she's one of them. Every single thing I have tried, intensely suicidal. Every time she comes to me, she says that, doctor, I know that you have been telling me, yeah, actually, initially you tell them, don't worry, 3, 4 weeks, you will be much better, ma. I don't promise, but I'll say that you'll be much better. 3 weeks have gone, 3 months has gone, doctor, 6 months. You keep telling all those things. I'm not going to become all right, doctor. I want to commit suicide. Every time she comes and tells me that I want to commit suicide. It used to be like, but every time I used to tell her and the husband one thing. She is going to become all right. She has to become all right, sir. When I know. That is why that question I said that the caregiver has to take care of the suicidal. Caregiver has to take care of the overindulgence of mania, all the spendings and then going around overactivity and all those things, prevent the suicidal attempt. She's correct. If I can convey that, definitely she's going to recover. She has to recover. She will recover. It's a matter of another 2 months or 3 months. If you believe that, if you convey that to the relative or the patient, don't you think it makes some impression? Please don't say that I am not promising. But if myself, I don't believe that the bipolar disorder episode is curable, I'm not going to say that. What difference does it make? It makes a difference when somebody is down in the dumps with the depression. Sir, it makes a difference. It makes a difference for the relatives. They are lost. So that is why I put that question. And fantastically, your belief, this is a concept. Suppose you make a diagnosis, schizophrenia. Fine, I know. There can be a possibility of a very good improvement, great improvement. Don't worry, it will be. But you will never recover. OCD, you will never recover. Child psychiatry, any of those things, you will never recover. We have one entity in psychiatry, which is a mood disorder, which is a good prognosis. Even that, I think systematically we are destroying, talking about functional recovery, 7 drugs, and then so-called mood stabilizations, and then continuous lifelong medication, saying that, tell them that episode is curable. 10 years, 3 to 4 episodes. Come back later, I'll see. Early warning signs, like signature relapse. Things, see that what you can. If you can't do, then let's not go by the theory. That is where I think sometime back I equated this with sort of, something like one of the political theories. Theories look fantastic, but it comes to the practice, it doesn't. That is why this is very, very, very important. Have a clear concepts. As long as we keep, when you diagnose bipolar 2, only 2 questions I ask. What is the duration of hypomania? What is the disability it produces? What is the duration of depression? What is the risk of suicide in this? What is the drug I am treating with? What is the confidence about quetiapine's antidepressant effect and quetiapine's anti-suicidal effect? And then whatever the other drugs. Think about it. That's it. You don't have to discuss it, but think about it. Otherwise, this is a problem. If you don't give this problem, he'll never reach here. This is going to be the problem. But even this, sometime back I was talking about it, even before the asymptomatic stage is reached, quite a lot of us are functional recovery is there, sir. I think we'll discuss sometime later. It's not always this has to be followed by this. We all do that as medical doctors. We do that. You as a medical doctor, private practitioner, suppose you have typhoid. 4th day your fever comes down, you go to work and then do. Your resident do not come because he is not bothered. Because you're a consultant, you go and bother the private practitioner. Functional recovery, I push myself. So that is also, it's not always symptomatic recovery followed by functional recovery. Quite a lot of times, significantly, some patients, functional recovery comes in spite of having the symptoms. That also we need to understand that. It happens. Yes, this is again rerun of some of the cases which recently I discussed. Lithium. One episode, one of you only commented, did lithium cure BD? It's not my statement, sir. Did lithium cure BD? Bipolar disorder. Only one episode. This is came to me with a diagnosis of it. This is a patient I diagnosed 2014. He's on lithium. 6 years. Fantastic. You can't find a better drug than lithium here if it is prophylaxis. But my worry is that my unfortunate thinking is that half the time I think, is it a natural process? That's where my problem is. This is why such a hue and cry about bipolar disorders. We say that over-diagnosis of bipolar disorders, over-treatment of bipolar disorder. This is the two cases of mine which I think I discussed in detail. This poor girl came to me with a depression diagnosis. I treated, she became all right. In this period when she had depression, there was a lot of irritability. I was sort of confused about the diagnosis of bipolar disorder. And then the depression episode went on for such a long time. This is what I told. My work of art by wrongly diagnosing somebody with a depressive disorder as a bipolar disorder. Same thing here. Clear-cut depression, she improved. Here there was some irritability, I was doubtful. Putting her, every time her depressive episodes went on increasing because of my wrong diagnosis of this being a bipolar disorder and not treating the patient with good antidepressants. She had depression signs, she has irritability, so I was worried that it could be bipolar. So you give lithium, you give risperidone, you give olanzapine and all things, and patient's depression went on, got prolonged. I showed you the whole, now like in the chart of it, how many months it went on like this. Finally, this is the price she has to pay for my overdiagnosis in not correctly treating this girl. We have to accept. You don't have the laboratory test. That's what happens. That's why we need to know, we need to discuss, we need to talk about it. Lithium is not all that rosy in every patient. Lithium, if lithium is the thing, it's in every patient. My God, it's not just a gold standard. It become one of the platinum or whatever it is. It doesn't do every patient does not. The same thing does not happen. Here also there's lithium. Here also there is lithium. Here also there was lithium. This boy was on lithium for 11 years, 2009 to. I discussed this case with you, 2009 here, and this episode went on for 1 year. That time somebody asked me, Dr. Reddy, you said that mania is not for too long a time. Usually chronic manias are not seen. What is this patient? Yeah, this patient. See this. This is where I said that the episodes, this episode, same patient. He's on lithium all along. Why this become? I don't know. But fortunately he recovered. So this is a kind of a picture in bipolar disorder. But every episode, this is my wishful thinking. Maybe some of you may say that maybe there are some subsyndromal things here. You don't bother about it. You overlook it. Possible. I'm not saying anything. But he's doing his business. This girl is fantastically. He's done his post-graduation, his job, and poor chap. And then he's a software professional, but somewhere he's going to find a job. So this is what it is about the three different cases. I think these are the, these are two patients and there's a three patient. And three more patients we discussed and I don't have it. Yes. All right. This patient we discussed last time. Yeah. This one, let me see. I think, this is again another reason. Number of weeks of this. I think this is where we thought we will discuss the cases today. Actually, we thought we'll discuss the cases today, but somehow I think it went on a different direction. 37% is the period of illness. That is out of 468 weeks of the duration of the total duration, there were happy episodes are only 176. That is only 37%. And this boy, it's only 4% of the time. It can, 2 months here, 1 month here. That totally it's about 6 months. I think I asked you, should I continue? I stopped lithium, no, because I think thyroid has, I don't know how many of you felt that I did a wrong thing in stopping lithium. I did stop lithium. Well, some simple lame excuse I took here and then stopped lithium just to want to try for myself. And then this is it. And this is, again, this is the boy. We're talking about 13 episodes. Only 15% of the time is. Then this is the boy I think he was talking about. Yes, he was talking about, why don't you start? Yeah, lithium 11 years, lamotrigine, olanzapine 2 years. But every time I started, I gave olanzapine. During the manic episodes, he put on a lot of weight. But I think definitely I'll follow your advice. I think now, like maybe I need one suggestion here. Do I go ahead and stop lithium here? Lamotrigine anyway I have stopped. 13 episodes, he was continuously on this period on lithium. Madam told that you increase it to 1.1, 1.2 level and give it a try. Do I do that? or enough is enough. Stop lithium and then look for. I'm not going to try valproate or carbamazepine. I'll go for one of these olanzapine or aripiprazole. Do you want me to try that here? I think maybe if some of you can suggest, I'll be really thankful to you. This is a patient. Now, maybe I think another 3-4 slides. I want your opinion on this. I want the group's opinion. The same way you have given me the poll answers, I want your opinion. Vulnerability, which I say mostly genetic vulnerability or childhood, like upbringing vulnerability, this is the stress. No stress, mild stress, moderate stress, severe stress, zero vulnerability, very high vulnerability. According to me, I think that is where somebody asked me psychosocial environmental factors here. Sir, psychotic depression, unipolar depression, bipolar depression. If at all there is a psychosocial factors at all, either none or if at all it is very insignificant, it doesn't play any role at all. For me, it doesn't play any role. If somebody says it does play some role, I'll give a small margin and say that, okay, it plays some role. Nothing more than that. This is where I keep looking at biological antidepressant, whatever drug you give, whatever ECT you give, whatever it is, it has to. The more severe, right? Grief reaction, absolutely. Adjustment problems, quite a lot of, but some of these adjustment problems could be MDDs also, I say that. But grief reaction, even grief also, if it is extended for a good length of time, MDD, it is included in MDD according to DSM-5, which personally from my side, I welcome it very well. But they were very clear about the guidelines. Every grief we don't want to, but when it goes beyond a period, get them back. The reason why here people criticize us if we give antidepressants. Here, this is antidepressants or medication, biological, pharmacotherapy. So I don't know whether you agree with this. The severe stress, it only gives some grief and then adjustment problem. For most of your bipolars and then unipolar depressions and illness, you don't need stress at all. These are like typhoids and these are like malignancies, these are like MIs. There are also some psychosocial factors in that. They're as equal as most of your medical disorders. I think I want your comments on this. This I showed actually in one of the lectures when I went to a psychologist group or a general group. I thought I'm going to be finished off on this slide. Surprisingly, 2-3 psychologists talked very much in favor of this. Yes, this is what it is. This is what it is. This is how it has to be. We have lost half a century in putting this as in all those theories and all those things. But now at least we have to come to a reality on this. Counseling is important. Reassurance is important. Putting your hand on a patient's shoulder, not in these COVID days, definitely. I used to have the habit of, generally putting it in. Now I consciously stopped it. Putting your hand definitely helps. Holding somebody's hand definitely helps. But that is not CBT. That's not psychotherapy. That is not going to cure depression. It is supportive. This comment, sir, I think definitely I invite discussion. I think we have some more time. And then reason why. I think we talked about MDD, diagnosis, and non-etiological basis they have made and all that. This is why, again, I don't know. Once again, actually today's slides are all in a frame, collected so that to see that why discussion about bipolar is important. This is one. Stress and then psychosocial factors do not play. And then this statement, where do we go? I want your opinion also in this statement. This is from none other than Nasigami. I think I showed you also. Large proportion of non-bipolar depression is de facto neurotic and then it's best treated with psychotherapy. Sir, if you ask me personally, I'm totally against this. The reason being, there are 2-3 simple reasons. I don't know actually. I have not practiced. I don't know about CBT. But every treatment has to be not only effective. I think last time I told it has to be applicable, replicable, accessible, affordable. Do you think this is affordable, accessible, and then now replicable in Indian setting? I don't bother about the Western settings. I don't care. What's the point in talking about it? Let them talk in the Western society if they want to talk. I have no problem. But we don't import that. We don't import. Whatever I know as a postgraduate recently, short-term psychotherapy is about 14 to 15 sessions. short-term psychotherapy. 14, 15 sessions, a patient coming, and then how much he has to pay for 1 hour sessions, and we say that psychotherapy, treat. Because drugs are antidepressant drugs are dangerous. Anyway, I'm going to another spin. Every time I come to that, I get into another spin. I'm sorry, and I'm going back and forth again. But this statement again, outrageous statement this is. This is the problem. This is the problem. That is why MDD has come into the picture. People are saying that don't give antidepressants to exogenous, only for endogenous. That's why MDD has come. And today, Nasir Gami says that no, like other than bipolar depression, there's nothing like unipolar depression. Everybody treat them with psychotherapy. Who is going to treat with psychotherapy and what kind of psychotherapy you're talking about? So the point is, you say unipolar depression, neurotic, so don't give antidepressants which are useless. You give psychotherapy. We don't have the tools to go ahead and then give psychotherapy. So the whole lot of developing countries, all the patients with the depression, what is the alternative, sir? Give me the answers. I'll be happy to receive some answers. This anyway, like, like these are some of the things which I like to have: good prognosis, heterogeneity, consensus treatment in acute bipolar depression. This is very definitely, first episode is out for me at least. I will not start because you saw that patient, that boy, first episode. After that, 6 years he is like that, but I'm continuing. Individual basis. We don't want staging in bipolar disorders. We want grouping in bipolar disorders. Staging is for schizophrenia. Staging is for OCD. Staging is for developmental disorders. Staging is for dementia. Bipolar disorders, it's a grouping. There's nothing like staging here. Right. Case reports I was talking about replace anyway. That's not it. This, I don't know how many of you agree with me. I have generally a feeling that somehow psychiatry is very much looked down by non-psychiatrist medical colleagues for whatever obvious reasons. Obvious reasons. At least that demands a paradigm. Looking at the thing, I was talking the other day, as in today, if you take MDD, there are 3 crore Indians who are suffering from major depressive disorder. There are about 7,000 or 8,000 psychiatrists. How will they treat them? Unless you get the rest of the medical fraternity into our kind of, like in our treatment methods. As long as you talk CBT and psychotherapy and all, they'll run away. They don't know. They know only 1 + 1 is 2 kind of a simple medicine, this thing. Okay, we all talk about holistic, but we need to be practical also. I feel that somewhere we need to, I always feel that we need to build psychiatry as a good valid medical specialty where people deal with psychiatric illnesses, which are medical disorders, with a specific pharmacotherapy, with a bit of a counseling, and they show good outcomes. Once you go to a psychiatrist, you are finished for life. No, sir. You can be all right. This is not just a wishful thinking. You can, suppose your medical colleague asks me, then yes, bipolar disorder is going to be all right, bipolar depression. Next episode, we'll see. I'll tell you the fact, but he's going to be all right. I think last time I told he can go back and study, he can go back and work. And that is one of these things, why I keep on talking about bipolar disorder, mood disorders, and then the area of interest and all these things. That's it. Thank you very much, sir, once again. Now, let me see that I'm sorry. I'm sorry, I'll do that, and then I'll go to chat, and then what are all the questions here?
Sir, we have Dr. M.R. Jawar, sir.
Yes. Sir, good evening. Welcome. So nice to hear you. Great.
Nice. Good presentation. Congrats.
Sir, thank you very much. Pranams. So nice. Coming from Varanasi, thank you so much.
Thank you.
Grateful. Sir, bole, sir.
Do you think that bipolarity is difficult to treat than schizophrenia?
Sir, when I say that, people keep making fun of me saying that, Dr. Reddy, because you are dealing with bipolar, you are saying that it's very complicated and trying to put yourself above the platform. Absolutely, you are right, sir. Bipolar disorder is a very, very difficult thing to manage. Every day, it's a kind of, people used to say that on the knife edge, you don't know when he's going to go into depression. You don't know when he's going to relapse into mania. It's always a problem. And it's always a pleasure if we can completely get them recover. Difficult, sir. You are perfectly right, sir.
Thank you.
So the Dr. Dushyant Deshpande is there. Dr. Dushyant, you can unmute and ask your question.
Yeah, before Dushyant comes live on the show, I'll say that one of the senior practitioners saying that in the last 30 years of my clinical experience, I've seen only one patient having mania more than 9 months. What best evidence? This Dr. Ashok Reddy's statement is here. What more you want? That bipolar disorder episodes are curable. 30 years, he's one of the senior practitioners. He retired as a principal. He says that in his vast clinical practice, there's only one episode. You would have seen thousands, not hundreds. Only one episode of mania. Then why are we afraid to say that mania is curable, man? Curable. Episode is curable. You'll come out of it. Thank you so much. That's it. So, Dr. Dushyant, I'm sorry. Dr. Dushyant, I'm sorry. When it comes to this, I sometimes take off a little bit. So, come, please tell me. Dr. Dushyant?
Sir, I think he is not there, sir.
And there is one question from one. Yeah, let me see. Like we have another half an hour today. Fortunately, every time I have been taking more of your time today, I think I made it a point that I'll cut short 30 minutes before and then give time to you, whoever is willing to ask. Whatever happens before that, let me now answer some of the questions what are coming here. Do we diagnose why bipolar disorders are biological? 100%. There is no doubt about it. I don't even put it as 99%, sir. They are biological disorders. I don't know what exactly, but they are like diabetes. People don't know why there is an insulin problem, but they are like that. Diagnose bipolar and schizophrenia in the same patient at different times. It's a fantastic question. It's a fantastic question. Something like somebody asked me, today he can have malaria, tomorrow he can have typhoid, like that. But that is where I think sometimes the concept of schizoaffective has come. But it may be, in my opinion, one of the very rare cases. If something like this happens, you know what my response? I'll put it as a bipolar disorder, currently with psychotic features, whether it is depression or mania. I'll look at it that. But no, at this point of time, schizophrenia, at this point of time, bipolar, I don't. But now, like good line of thinking is very good. I am now nice. Role of psychostimulants, right? But I'm a little bit worried about more than antidepressants. I'm worried about hyperactivity and then stimulant in mania. SGAs are considered having a mood stabilizing property. Why not SGA plus another mood stabilizer instead? Can we use? Can't we use only? Again, another very important question. Second generation antipsychotics, especially olanzapine, quetiapine, aripiprazole, have been approved by FDA for long-term prophylaxis. See, when you say that these drugs are by itself are effective, why do you want to add the so-called lithium or valproate or carbamazepine to this, making it a polypharmacy? Absolutely, this is what, sir, I think in the second patient where I discussed, I started the patient only on risperidone and then there were questions and I answered also saying that this is what I do. I think that's correct. The only simple reason being, let us minimize polypharmacy. Let us minimize polypharmacy. That's the only thing. I think definitely we should give it a try. Acute mania, carbamazepine, I do not know how far that is effective. Right, a subset of bipolar disorder patients respond very well to SSRIs in depression. Definitely, no doubt about it. No doubt about it. They respond very well to SSRI. I don't know how well they respond to lithium or quetiapine, but they respond well to SSRI. And then maybe there's a small group who do not respond to quite a lot of these things. We are lost sometimes. Maybe lithium, sometimes they respond. But by the time the natural course also may take off. Can't say that. Somebody also said less than 5% of chronic mania. Absolutely. When all of you say chronic bipolar mania, chronic bipolar depression is less than 5% or 2% or 3%, what is the problem for us in declaring that bipolar disorder depression episode is curable, bipolar disorder mania episode is curable? What a positive message you are sending across to the person sitting across you, the patient and the relatives. Don't worry, man, your boy is going to be all right. He's going to be recovered. But please take care. I'll try my best. He's going to be all right. Not all right after 10 years, in a few months. This is what psychiatry needs now. This is what psychiatry has created a kind of an image for itself that you go to a psychiatrist, that fellow writes ECT or gives you sleeping tablets and the rest of the life you take the medicines. No. I will cure the episode. I'll give you the possibilities of this. If you want to keep off medication, fine, sir. 2 years, 3 years, 4 years. I'm happy. That is why I asked the question, even the 10th episode also, are you confident he'll prognosis good? You said good. That's a fantastic thing about bipolar disorder. Bipolar mood disorders is one disorder. If psychiatrists all over the world collectively start looking at it as a good prognosis disorder, episodes are curable, symptomatic recovery is the rule. This is going to be a game changer for psychiatry as a specialty. People respect us. People respect us as medical doctors doing something concrete to the patient. Relatives respect us. Your non-psychiatrist colleagues respect us. Not talking about all vague things. That's it. That's what I want. That is why I discuss about bipolar disorder again and then again and then again. That's it. Nothing else. Stress, oh yeah, right. Somebody said the stress vulnerability, they'll agree. Great. I thought there's going to be, again, there seems to be, I think I'm old fashioned. People have agreed. That's very good. Absolutely. You don't need much of a stress for psychotic depression. You don't need a stress for bipolar disorder. You don't need a stress for recurrent depressive disorders. No, it comes like that. What is the thing? Antidepressants in bipolar disorder, I do write, sir. Sir, Dr. Ramanujam, so nice to see you here. I do write fairly regularly, unless I want to try sometimes. But when somebody, suppose some patient, I'm treating a patient with mania, suppose I'm treating with risperidone along with lithium, or suppose while the patient is on risperidone, if he gets a severe depressive symptoms, first thing I do is that not starting antidepressant or anything, I reduce risperidone because a lot of times I feel that itself is depressogenic. Once you come down, then I'll start antidepressant. I do start fairly regularly. I don't say everybody, every patient, because I do believe in the episode being a natural recovery. I do, right. How do you manage? So, Dr. Nirmal, the problem is my knowledge about schizoaffective disorders is very, very minimal, because maybe this is a blind spot I purposefully created for myself. I agree. For a long time, I created for myself a blind spot for mixed affective disorders, but I think I seem to be a little bit lucky in this management also. DSM-5 has thrown it out. Schizoaffective disorder, there are one or two very good articles of Jin Mali where he discusses the concept. But even today, it's a little bit of like floating side, not on a very concrete side. Management, if you force me, if you diagnose a case of schizoaffective disorder, and I happen to see that patient, if you force me, how do you? I will treat him as I treat an affective disorder with some psychotic symptoms, not as a schizophrenia. I'll tilt on this side. Yes. Somebody wants to talk? Somebody would like to talk? I heard somebody. No?
Yeah, Dr. Madhav Das sir or Dr. Suresh Kota sir.
So somebody, Dr. Madhav Das? Yes, I know you. Welcome, please. Sir, would you like to say something?
No, please carry on, sir. Please
Oh,
carry on.
okay, right, sir. Is hypothyroidism reversible after stopping lithium in long standing? This is something which I think last time I told I wanted to experiment, that's why I stopped. Suppose the patient is so-called well stabilized on lithium, is doing very well, prophylaxis, the small group of patients. I do not stop lithium, I'll give him Thyronon. But I'm always careful about if the usefulness of lithium is suspicious, I will hasten to reduce lithium, because why do I am producing another illness which he has to take medicines for the rest of his life. So that way, and I found it reversible. I found it reversible. If I stop it, it may take a little bit longer time, but reversible. Lurasidone, I did use. Here, let me confess. I did use, but at the same time, a lot of times I wonder, did I use it for good length of time? Did I use correct dosages? Did I was dependent? May not be. But as on today, plus minus, I can't really talk about it. Is depressive adjustment disorder being overdiagnosed as MDD? Yep. But the thing is, here, maybe sometime later we'll discuss. Lot of adjustment disorders do happen with some kind of a personality background, personality disorders. I think sometime back I told, but now once again I tell here, OCPD, obsessive compulsive personality disorder, is one disorder which responds fairly good with SSRIs. As somebody told some time back, somebody made a comment saying that if quite a lot of, sir, please don't mistake me, please don't generalize this. I found it useful in quite a few marital disharmony cases. If I find one of the partners having a OCPD, giving them a small dose of escitalopram is helping greatly. So here, you can definitely go ahead with your counselings, but also a request is that give them a small antidepressant, SSRI also. What to do when first presentation which shows like bipolar and borderline is a differential diagnosis? Hold it. What's the problem? Why are we in such a hurry to diagnose, like this one straight away bipolar disorder? We'll hold it for some time. Let's hold. Let's hold it for some time. What's your problem? We'll wait. Treat them what it is, and then we'll see what comes. And then slowly later you can. I think one day we'll take up bipolar disorder and borderline personality. It's going to be very, very useful. Okay. Treatment strategies with adjustment disorders. I do give antidepressant, but counseling definitely you need to take. I have to say that counseling is very, very important. Talking to them, discussing with them what are the issues, and trying to see what best we can do. Plus, give. That's where I said that escitalopram is a safe drug, and then you give it. Sertraline is a safe drug, and give it like that. Aripiprazole as an anti-manic. Again, it's a good drug. It's a best thing is aripiprazole. Some of the great advantages are it's non-sedating. It's a drug with a long half-life. You can even give it twice a week. But the only problem is this non-sedating, whether it goes against, like in the management of mania, because mania, it's a hyperactive and then hyper, they need to be calmed down slightly. Whether that will give some problem, that is where the thing is. And in the long run, I think Dr. Iswaran also was talking about his favoritism towards aripiprazole. I am also trying to see that a small doses, the way I am dealing with olanzapine, aripiprazole in a small doses of 5-10 milligrams, as long as it doesn't produce akathisia. If it produces akathisia, problem. Without that, EPS is relatively less. That can be a very good drug in the long-term management, but can be, I don't know about it. It's even given as a add-on for the MDD also, like an augmenting agent, that can be a good drug. Recurrent, oh yeah, right. I think it's a recurrent brief psychosis. Sir, what is that recurrent brief psychosis if it is not a mood disorder? Nothing. See, psychosis, schizophrenia, bipolar disorder, all your delusional disorders and acute transient and drug induced and all, keep it aside. If it is a long term, it has to be one of these two. Delusional disorder, leave it. Then if it is a recurrent episodic psychosis, it has to be episodic schizophrenia or bipolar disorder. Episodic schizophrenia concept, sir, it's, I think last I heard was Manfred Broiler, and after that, not really much. So it has to be. Recurrent psychosis is, for me, it's a bipolar disorder. Inappropriate laughing by itself does not say anything at all, but no, like I say antipsychotic, but giving valproate or lithium without a diagnosis of lithium without a definite diagnosis of bipolar disorder, I don't think. Lithium was greatly praised as a drug which made a pharmacological dissection. Without us having any diagnostic tools or something, this is the drug which made a pharmacological dissection of psychosis. Lithium responders, lithium non-responders. Lithium responders are affective illness. Lithium non-responders are thought disorder group like that. But somebody who is not, for a short term, you can do anything, but on the long term, I do not suggest. Personality disorder with impulsive traits, this is what we have been doing. Personality disorder, this is the important question. Personality disorder patient with impulsive traits and anger outbursts, use of valproate, carbamazepine. If you ask me, I don't use valproate, I don't use carbamazepine. I consider the, what is that? Impulsive traits, anger outbursts. I look at it as a personal disorder of either OCPD or borderline personality. Both of them, I give SSRIs, but I'm not talking that authentically that they are very effective. Like they do help. They do help a lot, predominantly because borderline personality, the risk of MDD is very high. OCPD risk of MDD is very high. Maybe as somebody has, I think a long time back, that book, Listening to Prozac, Peter Kramer told, OCPD, is it a form of frustration of OCD? If it is that, it's helping. I believe in that. So SSRIs do help. Not valproate. I don't write much of that. That's it. Acute transient psychosis. This is actually one problem. So one of the major things which I find at loggerheads with ICD is always a patient comes with a psychosis episode. He is in psychosis. How can you say that it's a transient psychosis? You make it diagnosis of transient psychosis only when the psychosis is recovered. If it is a short term, then only you make it as a transient psychosis. I don't know. ICD says that you make acute transient psychosis. Sorry. How do you know that in the acute psychosis is going to be schizophrenia or schizophreniform or something else? So I always find it funny to call it as a transient. The way they ICD-11 put the duration for hypomania several days, the same way transient is a short period that comes only after the psychosis is over. Before the psychosis is over, how can you say it's transient psychosis? I approach this as like acute psychosis and wait. After 3 months or 4 months, I stop the medicines and then see how progresses later. Yep, it's just a very difficult thing. Young patient with mania switch after escitalopram, and after mania subsided, he continues to be irritable and at times has OCD. Now, how to proceed? Right. Let's see that. Here I have a few questions. Did you make a diagnosis of bipolar disorder in this case? If yes, the approach is slightly different because you're looking at a long term. If it is only because you gave escitalopram, he had a brief manic symptoms or hypomanic symptoms for a very short period, which subsided once you removed escitalopram, then maybe I think immediately let's not jump to the conclusion whether it is that. In that case, OC symptoms have come. Treat the obsessive compulsive symptoms with your SSRI, but slightly on the lower dose and see how he responds. But always keep in mind, this man seems to be having some vulnerability for this antidepressants induced slight highs. Because exactly the same question some time back I heard, and then nobody was able to give an answer. It's a similar thing like that. But if it becomes a bipolar, then it's the next question. If you remember, the last patient, last but one patient which I showed, patient has relapsed into mania. I diagnosed as mania, but I didn't completely stop escitalopram. I reduced escitalopram and continued when I gave an explanation saying that he has got a predominant, one is resistant depression, second thing is predominant OC features. That is why I took the risk of, this may look paradoxical, and then, like it goes totally against, somebody will be getting jitters already there. Patient already in mania and he's continuing escitalopram. I do that sometimes if the OC features are significant, but it's always with trial and error. You're taking a small risk and see how it goes. These are not straightforward cases. Oh yes, right. Strong family history of bipolar disorder and patient comes with depression. Can we use antidepressant?
Hello.
Yes, somebody would like to say something?
MS.
Yeah, sir, yeah.
This is said that suicide is more common in the bipolar patients rather than MDD. What is your experience?
So looking at it, they may be taking it as a percentage. They say that it's more in bipolar. One of the reasons I say is that bipolar disorder, even though signature episode is mania, but patient spends more time in depressive episodes. So even though diagnosis is bipolar disorder, the patient spends a longer time in depressive episodes than in manic episodes. And then especially the way we are treating, I may be wrong, we are treating with the assumption that don't give antidepressants. I do not know what is the anti-suicidal effect of quetiapine and then YFC, whether that also adds to the increased risk, or the turbulence of both mania and depression increased risk, but depression risk is high, slightly, sir, at 2-3% high in bipolar disorders. That is why all the more reason, I think one of the slides have shown, the risk of suicide in bipolar depression is 60 times more compared to risk of suicide in mania. And the bipolar depression, we are not treating it properly, correctly, authentically, with a clear-cut guidelines. That is the sad thing. You're right, sir. Strong, yeah, I think strong Chintan, we have another 5-10 minutes.
Yes, sir.
Strong family history of bipolar disorder, patient comes with depression. Can we use antidepressant? Absolutely, I do use. Because I have seen family history is a very high risk factor, but doesn't mean that everybody will become bipolar disorder. So you treat with antidepressant, see how the depression responds. Once the depression responds after 4 months or 5 months, 6 months, stop antidepressant and then wait. Tomorrow, if he becomes a bipolar disorder, treat. I think this is an excellent question. This is an excellent question where the spectrum disorder concept falls into this. The moment there is a family history, yes, I am concerned. I take notice of it. I have written bold letters in my data sheet, but doesn't mean that I don't treat with antidepressant and treat something else. Exactly. Quite a few times it may not. We all know about attenuated psychosis syndrome, APS, at arms, early signs, it's not like at risk psychotic syndromes in schizophrenia. Only 30% after the end of third year, they become psychosis. So you're not going to treat every patient with APS or arms with antipsychotic. The same way, wait, keep a note, keep a red line, red flag, but treat with antidepressant. That is what I say. Yes, very, I think it's a wonderful question. Episodic substance use disorder, lot of times I take it as a secondary to the mood disorder. Substance use disorders are extremely difficult. See, it may be my wrong perception. I don't know what my colleague, Dr. Ramana, who is a specialist in substance use disorders, is going to say that I'll take the opposite thing. Mood disorders are excellent prognosis disorders. Substance use disorders, with all apologies to Vivek Bengal and then other people, they are very difficult chronic. Primary mood, the substance use disorders are very difficult. You don't even have a drug to treat them. Those who recover I always look at them that was it a secondary substance use, secondary to the mood disorder. Keeping that will help a lot. Keeping that once again, I'm coming back to that. Somebody I diagnosed as a primary alcohol dependent syndrome. I tell the relatives, we will see, ma, we'll see, it'll become better. Let's see what we can do. We have to do this. Suppose my diagnosis is secondary alcoholism, it's secondary to the mood disorder. I'll tell them that this boy is going to come out of it. Give me some time, give the medicines. He's going to be completely out of alcoholism. I don't think most of you think it's a rash statement, no? But that is right. I'll do that. We have to, unless our concepts are clear, we can't convey it. You don't have to say, I told you. We don't have to say in so many words, yes, I promise, no, I don't promise. Our body language. देखेंगे, बाद में देखेंगे, बाद में discuss करेंगे, we'll see ma, let's wait ma, different. Don't worry, he's going to be all right. Shalom, he's going to be all right. That comes only if it is viral fever. That comes only if it is tuberculosis and you have anti-tuberculosis treatment which is effective. That doesn't come for the backache. That doesn't come for the headaches. That is the difference I'm trying to put it across, stress it across. Alcohol use disorder, I treat manic depression, but alcohol, if I take it as secondary, I look at it as a more positive prognosis. Oh, right. When do you taper off the medicines? Here I go a little bit rash. I'm accused of it. Suppose it's a first episode mania. I treat. Suppose it becomes all right in third week or fourth week. I continue the medicines for 3 months or 4 months and then I stop it. Reduce and stop it. I may not be, textbooks, some of you may question that, but I do it. Suppose immediately he has like an exacerbation. I'll come back to that because I see that significant group do well after that. So I give that better chance to them, but I'll explain to them. That is how I do that. But otherwise, suppose he's recurrently having it, then I'll have difficulty in that tapering off unless I see for a reasonable, stable period of about 1 year or 2 years, I will not do that. Now, because you talked about it, I do not know why CanMed 2018 removed the fused remission and recovery. Let us see. A patient with depression, HAMD 30, improved, HAMD 6, remission. Today, she came to me, I did an HAMD, it was 6, remission. As of today, what we see is that this remission, which is sustained for the next 8 to 12 weeks, less than HAMD, less than 7 for the next 8 to 12 weeks, then I call it recovery. Because I want to give the stability to the treatment. But now CanMed says that once it is less than 7, remission, no more remission, this is recovery. But I think even this goes against our principles of even general medical practice also. You treat diabetes. Suppose your blood sugar is one day 100. You don't call it as completely. You wait for 3-4 readings and then you say that, okay, it's reasonably stable and then this dosage is enough. That's why that HbA1c has come. Even the hypertension is the same thing. Even most of the disorders, once fever comes down in typhoid, one day totally afebrile, you don't say that he is recovered. Okay, but next day he may have slight ups and downs. So, but I don't know what are the reason why they fused remission and then recovery and removed the term remission and relapses together. That would have been much more easier here to taper off. Wait for about 8-12 weeks and then taper off. Well, the mild energy, high mood does not tell me anything, sir. You tell me that it's an episode for 7 days or 2 weeks. Then we are not like none of us are like this. I think sometime back I told you, Sthita Prajna se Asha. No, we are all like this. If it goes like this, then we take notice of it. Minor things, I think we have to leave it at that and then wait. Let's wait. What is the problem? Episodic use of, fairly common. Episodic use of alcohol in bipolar disorder, mood disorders is fairly common. Self-medication of depression, I think, sir, sometime back, I think last session or few sessions, I think Jawar Saab has asked a question, suicides are high in bipolar disorders. In that context, I'd say that depression is more common in females. 1:2. Suicidal attempts are more common in women, but suicidal deaths are more common in men. We were trying to debate what is the reason, what could be. I showed you one slide where men do not go for treatment. 25% of women go for treatment of MDD. Only 7% of men go for treatment of major depressive disorder, whatever may be the cultural reasons, social reasons. One of the things is that they hit the bottle. They become more alcoholic, self-medication, possibly that is it, then it's a good prognosis. Dual diagnosis, yes, dual diagnosis, that's what. If it is a primary alcohol dependence syndrome and then a mood disorder together like that, we have trouble. We have great trouble, but even that, sir, I'll tell you, textbooks talk about a very high incidence of substance use disorder in mood disorders, but at least in India, we don't find. Use is there, dependence is very limited. In our center also, we have done statistics, hardly about less than 10%. It's not that 40-50% of patients with bipolar disorder have substance abuse, especially alcohol dependence. We don't see that. But when it is primary, this it's a bit of a difficult thing. It's not easy. Once your alcohol or any drug intoxication itself sometimes confuses you whether it's in the acute manic episode or just a simple alcoholic intoxication. That's why it's quite difficult. Clozapine-based bipolar 1 have fewer relapses. Don't know. I don't know. Clozapine is not the first line. Clozapine is the later choice, that also not so much of like an evidence-based. And clozapine, you use it valproate, it's very good. Clozapine has the problem of like an epileptogenesis is high, seizure threshold goes down. But clozapine, I have a big problem. It's an extremely sedating drug. Extremely sedating drug, which I don't want to use in bipolar disorder unless I have 2-3 patients. I have 2-3 patients. But how much of? Recently also I had one patient, wasn't clozapine 100 milligrams, but after 7-8 years he had a relapse. Can't say. Number one is extremely sedating. Number two, okay, the seizure threshold I'm not so much worried about. But the most important thing is I'm worried about the release of OC symptoms, which itself can be a big problem, especially in the depression component and all that. So I do use, but not many patients. I'm not so much bothered about the granulocytosis and the risk, but we have to be a little bit careful about the cardiac risk, especially in the first 2 weeks. Oh, right. Have you ever used valproate? For almost about half a decade, I was using only valproate. I think I told you sometime back. I did a debate with somebody, lithium on that side, valproate on this side. I could say 1, 2, 3, 4, 5, 6. These are all the things. Because if it is useful, if it is effective as a prophylaxis, if it is a good drug for the prevention of the next episode, any day valproate is a safe drug. No doubt about it. Absolutely no doubt about it. But without that, giving it for increasing the polyform, see, that is the only thing. So thank you very much. Today, I'm happy that we could finish at 10 o'clock, and then thank you very much for all of you being here, and it's a wonderful session. And at the end of the day, I don't know whether I could, why there is such a hue and cry about bipolar disorders. As I told, one is that that's the only thing I know, that's why I talk about it. Second thing is that the point, good prognosis disorders is, I see it as a big hope for psychiatry as a medical specialty. And then if we can do that, if we can show the results, it's going to be a game changer. It's going to make all the difference for the establishing psychiatry as a valid kind of a one, very, very useful medical specialty, gives us respect from our medical colleagues also and in the public. And treat well, stigma goes down. Stigma goes down, awareness goes up. Awareness goes up, you see more patients and then more result, more positive thing. That's it. That's going to be the most important thing. Thank you very much, sir. I think there are a lot of people here. A special thanks to Dr. Jawar Saab, Dr. Nirmal, Dr. Dushyant, Dr. Ishwaran, and then all of you. Thank you very much. We'll see you again next Tuesday evening. Thank you, sir.